Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health Doc Talk. These are real conversations with physician experts from around the largest healthcare system in the Maryland, D.C. region. Breast cancer is the most commonly diagnosed cancer among women in the U.S., with more than half of those diagnosed at risk only by their age and gender. Perhaps it's the attention breast cancer has achieved through the years that has driven changes in technology and medicine, even the guidelines for screenings. But clearly, the impact has been significant. Over the past 2 decades, more women are getting a diagnosis earlier in the disease process, and fewer women are dying. Finding breast cancer requires science, technology, a talented medical community, and sometimes maybe even a little luck. We are covering the gamut today. Can we leave a mammogram feeling confident? What about women with dense breast tissue? Diagnostic radiologist Dr. Michelle Townsend, who is the chair of the Department of Radiology and section chief of breast imaging at both MedStar Good Samaritan and MedStar Union Memorial Hospitals in Baltimore, is going to walk us through the answers to those questions and more. I'm Debra Schindler, your host. Dr. Michelle Townsend, welcome to MedStar Health Doc Talk.
Thank you.
You're a diagnostic radiologist, which really, what is that? 4 to 5 years of medical school, additional radiology training. Is that accurate to say?
So 4 years of medical school, a total of 5 years of residency, and 1 year of fellowship. Gosh, 11 years.
That's a lot of school. I mean, because we've all seen mammogram images, and to the untrained eye, like mine, I would never want to be put in the position to try to identify cancer. What is it that you look for?
So we look for symmetry. So everyone is pretty symmetric, meaning your breasts look the same right to left. So we're looking for subtle asymmetries, meaning subtle differences between right and left.
Right and left breast, or right and left side of the breast?
Right and left breasts. So the right breast and the left, in 95% of patients look the same. So we're looking for subtle differences in the left compared to the right. And within the differences, we're looking for masses, which look commonly like balls. We're looking for calcifications, which are kind of like little pieces of salt, if you can picture that. And we're looking for
calcifications are good or bad? Are they
both?
Do they indicate cancer?
They can, depending on the size of the calcification and how they're distributed in the breast. It can give us an indication as to whether this can be a problem or not.
When you go into looking at these images, do you have knowledge of any symptoms that the patient might have had, or are you just looking, at the image independent of any other information?
We're looking at the image independent of any other information. If a patient has any symptoms such as breast pain, nipple discharge, itching, and so forth, that's a diagnostic mammogram, which is a problem-solving mammogram. And then at that point, we would be alerted, and that's a different type of test.
And what about their family history? Is that something that you're informed of?
Yes. When you come in for your mammogram, you're asked a list of questions that include your family history in order to generate an overall risk assessment score.
I ask because I've seen doctors who are in the imaging room, right, sitting there in the dark room looking at these images, and I'm wondering, how long do you study that? How long are you looking at that to try to discern a dot or a speck that could be breast cancer? It feels like a lot of pressure to find that, to make sure that you don't miss something. I guess it doesn't always stand out.
It can be very hard. It can be sometimes the area of interest can be mass. So in order to level set everyone in terms of what we're looking for, I liken the breast to the sky. Breast fat is black, which correlates with the sky being blue. Breast tissue is white, which correlates with clouds in the sky. So everyone has different ratio or different amount of sky to breast tissue. So the challenge becomes breast cancer is white and breast tissue is white, like the clouds. So the cloudier the sky is, the denser your breast is, and the more challenging it is to interpret the mammogram.
What do you see that raises a red flag?
All of us have a systemic pattern of how we interpret images in order to decrease variability and therefore decrease the possibility that we overlook something. There are areas on the film that we wouldn't expect breast tissue or breast tissue to reside. That's one thing. There are subtle differences between the right breast and the left breast that can also alert us to there being a problem.
Okay, so there's different types of mammograms, and I know just recently I scheduled a mammogram, and they asked me on the phone, did I want to pay $40 for something else that would help them see more clearly? And I was like, yeah, of course, I want you to have the best possible chance of finding it. Well, insurance doesn't cover it, which is weird to me. But anyway, what are the different types of mammograms?
So currently there's 2D mammogram, 2D digital mammogram, and then there's also tomosynthesis layered on top of that. At this point in time, most insurance companies are reimbursing for tomosynthesis, which is 3D mammography. So if you think about 2D mammography like a loaf of bread, and you can see that it's a loaf of bread, and you look at it from different angles to see, and that's what we're doing to kind of see if we can find something abnormal. If you think of 3D mammography as the slices of the bread. So you slice through the bread, and that's the way we get a better look at what's inside that loaf of bread. So that's 2D versus 3D mammography. Currently, the extra charge that offered at time of image interpretation, depending on the center you go to, is for breast AI.
AI?
Artificial intelligence, which can help, which gives an overall grade to the grade of suspicion of whether the mammogram that the physician is reading is suspicious for cancer.
That is something that is very new, right? I mean, I've never heard of that. Even when I talked to her on the phone, I didn't get that explanation.
That's what it is. So initially CAD, so everyone has CAD, which is a sort of AI. It was very sensitive, meaning that it would highlight sometimes the entire mammogram as being abnormal, which is not useful.
That would be an inconclusive?
Oh, not necessarily. Result? So for screening mammograms, we'll look through them, and at the end, the AI pops up, and it will mark things that the computer algorithm thinks are suspicious. The challenge is they mark a lot of things that are not suspicious. So then there's a whole bunch of noise, and it makes it harder to interpret. And to be perfectly honest, it's very distracting for some radiologists. But that's what we have baseline. Most centers who have 2D mammography have that at least. So now there are newer algorithms of AI coming online. And so those are not necessarily reimbursed by insurance companies yet. I feel like within the next couple of years, that'll be part of the charge.
So when we're in a Word doc and the computer tells us that we have a misspelling, it's the same thing. It's telling you that there's something suspicious here?
Yes, correct. So for one of the more common algorithm AI, I won't say the name, they'll give a grade as like A being most suspicious to D being least suspicious or something like that. And it'll say, oh, this is very suspicious, this area, you should take a better or tighter look at it.
And from there, what would happen? You would recommend?
So from there, if the algorithm says, you know what, this is a really suspicious area, we look at it independently as well. Then we'll call the patient back for a diagnostic mammogram, which is a problem-solving mammogram, to do dedicated images to see whether or not the area really is suspicious or not.
And how would those mammograms differ from the originals?
Diagnostic mammography uses typically a smaller paddle and different paddles in order to optimize the area of concern.
Like a close-up, a zoom?
Exactly, a zoom feature.
At what point would an MRI be called in as an additional diagnostic tool?
So currently we use breast MRI for high-risk screening in patients who have a greater than 20% lifetime risk of developing breast cancer over their lifetime. So there's a subpopulation of patients who, in addition to screening mammography, also get screening breast MRI regularly. We also use breast MRI to evaluate response to neoadjuvant chemotherapy and those patients who have had a known diagnosis of breast cancer and they received cancer treatment prior to their definitive surgery for a better cosmetic result. We use breast MRI to look for implant integrity for patients who have implant and there's concern for rupture. That's also another tool in how we use breast MRI.
Okay, so not necessarily for breast cancer always.
Not always for breast cancer, but that's the primary indication is high-risk screening.
As a patient, how would I know which mammogram I should be getting? How do I differentiate? Because I don't know what DBT and 3D images and S2D mammography is.
Fair enough. I think at this point, at least in the state of Maryland, everyone should be having digital mammography. So everyone at least has digital mammography.
Is that enough? Is that enough for us to walk out of a mammogram and feel confident? They're going to find, if I have it, they're going to find it.
Optimally, what you really want is a 3D mammogram. And you should probably ask to ensure that the site that you're going to has 3D mammography. So you have to actually advocate. So at least everyone's getting 2D in the state of Maryland, but are you getting 3D?
What are some of the other ways patients may find a lump or may find breast cancer?
So some of the ways that patients can find their own abnormalities is by doing regular self-checks, regular self-breast exams. They will know their breast tissue better than anyone, including the physicians that they go to. This point is very important in terms of advocacy. So if you go somewhere and you feel something and your physician says, "Oh, I don't really feel anything," and you know that it's different, it is up to you and a part of your responsibility for your care to assert yourself to say, "This is something different and I need a diagnostic mammogram and ultrasound."
If they do feel a lump, does it hurt?
Most commonly, they do not.
So if it hurts, chances are it's something else.
Correct. And the something else, depending on the age of the patient, would be cysts in those patients who are still menstruating. Depending on the phase of menstruation, it usually gets more painful just before the period. And so there commonly are cysts. And if there's ever a question, please come in to get the diagnostic mammogram and ultrasound so that we can put the case to rest.
And ask for 3D.
Ask for 3D.
All right. We talked about an MRI.
Yes.
There are some uses for that in finding breast cancer. What's thermography?
Thermography is, I liken it to a heat map, if you will. And ostensibly, if there's increased heat in an area, that might indicate that there's underlying cancer. Thermography is not a validated method of finding breast cancer. Okay. So that is not a screening tool people should employ regularly or at all. At
what point would a doctor ask for a patient to have a thermogram?
From what I have heard, I don't know if it's necessarily physicians asking for patients to have a thermogram versus patients not wanting to get a mammogram because of the pain or the radiation. So this is an alternative method that is thought to find breast cancer. However, it is not sensitive, it is not specific, and it is not an alternative to screening mammogram. Like, it's just not.
It's not a reliable tool for finding breast cancer.
Right.
Okay, we'll scratch that off the list. Tissue sampling, biopsy.
We do biopsy once we do a full diagnostic workup using imaging. Sometimes there are occasions where surgeons will biopsy using palpation if we don't see anything on imaging, but that's primarily after a full diagnostic imaging workup has been performed and a physical exam, if the surgeon's doing it by palpation.
Now, as a radiologist, you would be involved with a biopsy sometimes when the lump is very small and you have to help with the imaging to guide the needle.
Correct. The goal of screening mammography is to find node negative cancers that are less than a centimeter. So that's why we do screening mammography. So if we're involved and patients get annual screening mammograms, we're able to find cancers that are small, at which point, depending on where we see them, if we see them best on the mammogram, we'll biopsy using the mammogram machine. If we see them best on the ultrasound machine, we'll biopsy them using the ultrasound machine. There are cancers that are seen only on MRI. And if we see them best with MRI, then we biopsy using MRI guidance.
Just to clarify, node negative cancers would mean cancers that have not spread yet. So
correct.
Are you referring to a DCIS, a ductal carcinoma in situ?
Yes, ma'am. DCIS as well as invasive ductal cancers that are very small.
How do you get around an implant in such a situation as that?
So when we do screening mammograms and even diagnostic mammograms, we also do implant displaced views. So the mammographers, the radiology technologists that take the images, they know how to manipulate the implant such that we can see the maximum amount of breast tissue.
They take more pictures.
We take more pictures. So instead of a standard 4, depending on the size of the breast, it can be up to 8.
Have you found breast cancer in a patient with implants?
Yes, I have.
Does it stand out? Is it as difficult to find as I have read it to be?
As long as the patient is appropriately imaged, and that means we include the maximum amount of breast tissue on the image, we can still find breast cancers with regular.
Mm-hmm. And you can biopsy them the same?
Yes, especially since most of the implants now are behind the muscle and the breast cancer is in front of the muscle. So there shouldn't be an issue of implant disruption with a biopsy.
Oh, you mean the implant is in front of the muscle?
Oh, most of the implants are behind the muscle at this point.
Oh, I see. Okay.
Yeah, so it makes it easier because the breast cancers are in the breast tissue.
Got it. Okay.
Before, when they were in front of the muscle, it was more challenging.
Okay, when is ultrasound a good method to use?
So screening breast ultrasound has been found to find 2 to 4 more cancers per 1,000 women in conjunction with mammography. So using screening breast ultrasound is very good for patients who have dense breasts. And dense breasts are patients who have at least between 50 and 75% of the breast volume has clouds in it. If we go back to our analogy of the sky being breast fat and the clouds being breast tissue. It's a good option. The caveat being that while it's very sensitive, sometimes the specificity can be a little off. So breast ultrasound is very sensitive, meaning that we can find things, but not all of them are going to be cancer. The problem is some things definitely look like cancer, some things definitely don't look like cancer, and then there's a bucket of things that we're not quite sure. If we're not quite sure, we're going to go ahead and biopsy them. And that can add cost and anxiety to patients. So, when we're talking about supplemental breast screening modalities, which include breast ultrasound as well as breast MRI, a shared decision making in terms of, we can do these tests. And they also might find other things that aren't cancer and that will require biopsy is useful prior to patients beginning on a supplemental screening protocol.
You said that sometimes they look like cancer. What would that look like to you? When you're sitting in the reading room and you are looking at a breast image, when is it that you say, oh, that's definitely cancer, that you already know without further diagnostics that it's cancer? What are you looking at in that case?
So it depends on the imaging modality. So in ultrasound, it looks irregular. On mammography, it also looks irregular. On breast MRI, we give IV contrast, which the contrast in MRI allows for us to identify areas of the breast that have increased blood flow. So depending on the level of increased blood flow, and we compare right breast to left breast, that can also determine whether or not we think that there's an area that looks like cancer. Depending on how the increased blood flow is distributed, once we give the IV contrast with breast MRI, that is also another indicator that this is cancer. Distribution also plays a part. This distribution of the imaging findings also play a part when we're looking at ultrasound as well as mammograms.
The contrast-enhanced mammography was the last on the list of other screening methods that I was going to ask about. So you got there before me. When is contrast-enhanced mammography the best option?
Contrast-enhanced mammography is a good option for patients who are unable or unwilling, for lack of a better term, to undergo breast MRI for high-risk screening. So it's just, we give IV contrast, the same that we give for CT scans, and we take pictures using the mammogram machine. So it's very elegant. And it also shows us areas of increased blood flow, which can indicate if there's a cancer there or not.
All right. So, and the contrast is delivered through an IV.
Correct.
And then you go through a normal
mammogram.
Does it usually take more than one of these tests to make a diagnosis?
That's a very good question. I think the best answer is that it depends. So if you're a patient at average risk for breast cancer, a mammogram with a fatty or scattered breast density, mammography will work very well for you. If you're a patient who has a higher risk or higher propensity of developing breast cancer over her lifetime because of family history, as well as layering on breast density, mammograms by themselves may not be the only test that can be of assistance. Usually a mammogram with ultrasound or a mammogram with breast MRI will maximize the likelihood that we'll find breast cancer.
The American Cancer Society reported that mammograms miss 1 out of 8 breast cancers, and women with dense breasts are more likely to get false negative results, which is a little daunting. Last March, the Food and Drug Administration, or the FDA, passed an amendment to the Mammography Quality Standards Act, or the MQSA, mandating patients be notified by healthcare settings about the density of their breasts. What is the MQSA, and explain what breast density means?
Breast density means the amount of breast tissue that's in your breast. And depending on the amount of breast tissue, it can be more challenging to find the cancer. Breast tissue is white and breast cancer is white. So the more breast tissue you have, the more challenging it is to find a cancer a white cancer on that background. The MQSA is the Mammogram Quality Standard Act, and it stipulates and it tells us and it informs how we perform mammograms throughout the United States. So it's a standard way that all accredited mammography facilities in the United States perform and interpret mammograms. Dense breast legislation has been in Maryland for at least a decade, and patients at MedStar Health do have the breast density actually embedded with the patient lay letter. When you come to the office suite to get the mammogram, the result letter that you receive will have your breast density. Like they'll say your breast is dense or your breast is not dense.
A, B, C, or D. A is almost entirely fatty tissue. Explain what B is. Scattered areas.
B is scattered, so it's kind of a scattered clouds in the sky. That's a B.
C, it says
heterogeneously dense breasts. So that's a mostly cloudy sky.
And then D, extremely dense.
Extremely dense. The sky is gray.
That has to be very challenging for you, especially you, first and foremost, before the journey even gets started.
Well, you know up front that this will be a more challenging mammogram, and you have a lower threshold for calling patients back because you're not quite sure, because you can't see as well. And then those patients, when they come back for a diagnostic mammogram, should we find anything, we make sure that we tell them at the time of image interpretation that you have very dense breasts and you may benefit from additional screening imaging, which would include breast ultrasound and breast MRI.
Why do some women have this? Hereditary?
It can be hereditary. Actually, approximately 40 to 46% of women who are of mammogram age have dense breasts. It also varies with weight. So the bigger you are, typically the more fat that you have in your breast so that we can see a little bit better. And as you lose weight, some people tend to lose breast fat. So then you'll have more breast tissue. So older women, a lot of them have dense breasts, if you will, because they've lost a lot of weight. And so they don't have breast fat. Getting
back to the MQSA.
Yes.
Explain what that is, because they have set up guidelines for getting mammograms, and that seems to change a lot. Is that because of this organization?
So the MQSA monitors how accredited mammography facilities in the United States perform mammograms and perform our quality control to make sure that we are obtaining images and are interpreting images accurately. The USPSTF, which is the United States Preventive Task Force, they are the ones that roll out mammography screening recommendations probably about every 10 years. So they just did an update which says, okay, finally they've gotten to, we should start screening mammograms at the age of 40, and we should do them every other year. 10 years ago, they said start at 50 and every other year. And they recognized that they were missing a lot of people who would have been diagnosed earlier had they started at the age of 40. There's a subset of the population, primarily non-Hispanic white, non-Hispanic black women, who have a 72% more chance of being diagnosed with breast cancer under the age of 50, and they are more aggressive. And the initial USPSTF guidelines starting at the age of 50 excluded women from that. I mean, they just weren't getting it. And part of the issue with USPSTF guidelines is that they inform how insurance companies will reimburse. So if the USPSTF says, oh, you know what, mammogram starting at the age of 50, then you go get a mammogram and your insurance company can say, well, that's not what the recommendation is, so I'm going to deny. So the public policy around screening mammograms is very important. So it started at 50 and then it backed down to 45, and now we're back at 40. But they still haven't said every year. They're still recommending 40 at the age of 40 and every other year.
Age 40, get a mammogram every other year, unless you have a problem.
That is what the USPSTF says. MedStar Health and the ACR and the SBI all say begin at the age of 40 and screen every year as long as you're in good health and intend to seek treatment if something should occur.
And would insurance cover?
Yes.
Even though that's outside the guidelines?
Yes.
Okay. And younger women who have a family history, what do you recommend for them? So
all patients should have a risk assessment done between the age of 25 and 30. So you know what your level of risk is, and then that can inform your screening schedule and whether you need supplemental screening imaging going forward.
And, we keep talking about women, and we are referring to these cases as a woman's problem, but we know that men also get breast cancer.
Yes.
Fewer.
Yes.
But if it's in the family history especially, we know that this puts a man at higher risk. What's your recommendation for them? Do they get a routine screening if their mother had a breast cancer and their grandmother had breast cancer?
Typically they do not. So the male breast cancers that I've seen throughout my career have always been felt. It's always palpated. So we've not been doing screening. Once they do get diagnosed, however, they do tend to come yearly if they haven't had a mastectomy, just to screen the other side. But screening high-risk male patients has not been actually a mainstream activity, to your point.
It's just interesting. I was in the infusion center in Bel Air and recognized a patient there getting a chemo infusion, a man, as someone I knew. But he found a lump on his own, and mother, sister, aunt, grandmother all had breast cancer. It never occurred to him that he was at risk.
Yeah, we don't really have those conversations with men as much. So once they find the lump and then you do all the diagnostics, then they'll do the genetic assessment and the risk history, and then they'll be like, oh. But yeah, to your point, we don't proactively do that with men as much.
Another surprise about that for most people is that men can get a mammogram.
It's not uncommon, primarily for something palpable. And then we do the diagnostic mammogram. And most commonly, it's gynecomastia, which is breast tissue that happens right behind the nipple. There's 4 phases of it. Sometimes it's painful. Sometimes it's not. Depending on the phase of gynecomastia, it can be reversible or it can't. And there's a whole host of drugs and medical conditions that cause it. The whole underlying theme is more estrogen than testosterone.
That is an important message for men then who may be listening, that just because they have a lump, it might not be cancer.
Correct. But you do need to get it checked out to confirm.
So by this point, it's clear that a radiologist will see something suspicious in the image. And then going down the list of what you might possibly visualize, I'd like to get your comments on each one of these. A mass.
A mass can be a multitude of things, so it's not always cancer. There are other benign things a mass could be, which include cysts as well as fibroadenomas. Depending on the appearance of the mass will determine whether or not the patient undergoes biopsy.
Okay, we talked about calcifications.
Calcifications are like little grains of salt. Depending on how big they are and how they're distributed in the breast will determine whether or not a biopsy will be performed.
Breast density.
So breast density also confirms an increased risk of breast cancer by itself. In addition to the fact that the denser the breast is, the more likely it is that it can mask a cancer. So there are 2 separate issues going on with breast density, which is why we recommend that those patients who have dense breasts consider thoughtfully additional imaging in order to maximize cancer detection.
I know we already talked about that, but who assigns that letter, A, B, C, or D? Is that you? Is that your role?
Correct. Within all our reports, we visually look at the breast and determine whether or not we believe that it's fatty, which is A, scattered fibroglandular, which is B, heterogeneously dense, which is C, and very dense, which is D. Additionally, we have AI tools that also independently evaluate it such that we make sure that we're in line and that we're not overcalling dense breast, because that does come with risk.
Asymmetries.
Asymmetry, so that's when the breasts look different, right breast compared to left breast. And depending on the type of asymmetry, it can just be normal glandular tissue in a small subset of patients, but it can also represent developing cancer and additional pathologies. So we do aggressively work those up and biopsy if necessary.
Okay, and then the final thing that you may see are distortions.
So distortions, I would lump those in with asymmetries. So distortion, if you think of a scar, so it looks like a scar. And so architectural distortion can be a result of prior surgery so that the breast tissue is altered in that area. Architectural distortion can also represent fibrosis, which is kind of scarring of the breast. And architectural distortion can also represent breast cancer. So if we see architectural distortion and there is no history of prior trauma and or surgery, then we typically will biopsy in order to exclude cancer.
What's the most unusual finding that you've had in your career, would you say? Any surprises?
I guess lymphoma of the breast.
Lymphoma of the breast.
Mm-hmm. Lymphoma. There was a lymphoma of the breast, which was surprising. And the patient came 1 week and it was one size, and came the next week and it was double the size.
The lump?
The lump was double the size.
And did the lump look different than a breast cancer lump? I mean, how did you know that it was lymphoma?
Oh, we had to do the biopsy.
So you saw something and then you ordered up the biopsy and it turned out to be lymphoma.
Mm-hmm. That was different.
Would a PET scan work for breast cancer?
PET can work for breast cancer, yes. We use that in staging, but not as a screening tool.
So you have to know that you have cancer to get a PET screening?
Correct.
I know that there is always that concern of unnecessary testing, and sometimes I hear that about mammograms. What is the downside of a mammogram?
So the purported downsides of the mammogram include patient anxiety, because if we call patients back for follow-up examinations, false positive mammograms, meaning we think that there's something there, we do a biopsy and it's not cancer, and pain. So those are the three primary ones. There's also a fourth one called overdiagnosis, meaning that we find things and we biopsy them. However, even if it's cancer, it may not have become manifest during the patient's life. The challenge with that is you don't know which ones will become manifest and which ones don't. So overdiagnosis can range, and there's a broad range ranging from 1% to like 50%. So there's a broad range, number one. And number two, we're unclear as to which cancers would have developed into invasive cancer. So when we talk about overdiagnosis, it's primarily in the spectrum of DCIS, which is breast cancer that's confined to the milk duct.
Which is a comfort to find out, I would think.
The breast cancer is confined to the milk duct?
Right, that it hasn't spread.
Correct. So that's stage 0. The most common manifestation of cancer that we see on mammograms is stage 0 DCIS.
Do you love your work?
I do. It's ever evolving and challenging.
Did you know that going into medical school, or did you discover that while you were in medical school?
I discovered that while I was in medical school. I enjoyed all the rotations. However, I didn't feel inclined to make a career out of any one of them. And so diagnostic radiology was my first rotation of my last year of medical school.
What happened? Was it a specific patient case?
No,
doctor?
it was the dark room, the happy residents, and it was the different imaging modalities that we use. So we use CT, we use X-ray, we use ultrasound, we use MRI, and it was a problem-solving piece. So I was very pleased when I found radiology in the last year of medical school.
Well, you seem very enthusiastic about the work that you do, and you seem gratified.
No, being a breast imaging radiologist is a different type of medicine to practice. I mean, you see patients at a very vulnerable time in their care, and it's a privilege to be able to partner with them. Every patient that comes through this hospital comes through radiology, and we make a profound impact on their care.
Well, we're glad that you made that choice. We've been talking with Dr. Michelle Townsend Day at MedStar Good Samaritan Hospital in Baltimore. Thank you for sharing your expertise with us.
Thank you for having me.
For more information on mammograms or to schedule one, go to medstarhealth.org/mammogram.